welcome very much. Welcome to our session. My name is Stacey Lally. I'm the Deputy Director of the Q community. If anyone happens to be a member of Q, do say hello as well in the chat box. I'm really thrilled to be here chairing today's session, around connecting strategic decisions to collaborative and equitable improvement work in practice. I'll say a few words about Q for those of you who aren't familiar. Q exists to collaboratively accelerate the improvement of healthcare. Our vision really is to have an embedded culture and practice around improvement that supports high quality care for all. So Q is a community of thousands of people across the UK and Ireland collaborating to improve. It's delivered by the Health Foundation and funded by partners across the UK and Ireland. Membership of the community is free to access, so it provides a variety of opportunities for learning, sharing, collaborating. Exactly some of the things that we'll be doing here today, including funding opportunities as well. You can find out more on our website. Do please get in contact if you are interested, want to find out more either for yourself or for members of your team. And we're delighted to be partnering with NHS providers and to have the support of the Health Foundation and NHS England on the programme, which enables us to draw on their kind of extensive work on this topic over many years and the learning from the community and a community of improvement leaders across the sector as well. There's lots more in store for this programme, so watch this space. Today is the latest in a series of peer learning events. So these learning events and resources are designed to help senior leaders within provider collaboratives in developing shared improvement approaches, which embed a focus on equity from the outset. Over the last year, through our events, we've explored various topics such as harnessing the power of QI to tackle inequalities, improving wait lists equitably, and the first steps to working together collaboratively in improvement and equity work. It feels like a really special place for people. We understand this is emerging work for most people, so it really is a great opportunity to take some of the learning from elsewhere, reflect on the role of senior leaders and yourselves and how these may apply to provider collaboratives. And because most people are at the beginning of their journey, that kind of safe space to kind of share and reflect feels really important, to discuss what the barriers are that you're facing, the enablers and the opportunities. So I'm really looking forward to learning with all of you today as well. In the next phase of the programme, we're working closely with 5 collaboratives through a bespoke peer learning and coaching programme. We'll continue to share the insights and learnings from that more broadly, so do keep an eye on the improvement programme on the NHS providers website for updates. And I have spent some time on the YouTube channel, and there is a whole load of stuff there that you can get into. I would recommend you doing that. So I'm going to kick us off by introducing our speakers. Really delighted to have 2 outstanding speakers with us who will share their experiences, perspectives, and their insights. I know they have a lot to say, and I hope you will have a lot to ask too after you hear them present. So a very happy welcome to Dr. Seema Srivastava, Deputy Medical Director at University Hospitals Bristol and Weston NHS Foundation Trust. She's also a member of Q. Welcome, Seema, great to see you here. And also Dr. Andy Heeps, Deputy Chief Executive and Chief Operating Officer at the University Hospitals in Sussex. Next slide, please. So before I just we get into the sessions, you'll see here some detail around our housekeeping. So this is an interactive event. It would be great if you could have your cameras on, if that's possible. It's always great to see people's faces when you're presenting and when you're having conversations, and it can really play a part in how engaged we feel in the sharing and learning. Please also mute your microphone when you're not participating. That just helps with any background noise and interference that we might have. And if you do lose connectivity, you can just follow the same link to rejoin the session. As I've said, it's an interactive session, so really welcome your questions and comments. We'll have Q&A time after both Seema and Andy have spoken, and then some more Q&A time as a whole towards the end of the session. So please use the chat function or raise your hand. And if you haven't introduced yourself yet, I can't quite see the chat box right now, then please do say hi. I'd love to hear from you. The meeting is being recorded, so the presentation can be shared and you can go back to it yourself if you want to dig into some of the content there. Next slide, please. Okay, final piece from me is about learning and reflection. I think we all do this in different ways, don't we? So this slide here shows something that you might have had in advance. I think there's a link there into the chat box as well. You'll see 4 different questions there to enable you to kind of think and reflect about what might be important to you in terms of what you're listening, any questions you might have. It's entirely up to you, but sometimes I find these tools can be really helpful when I'm doodling and trying to make connections, and sometimes I draw it as a bit of a sketch note as well when I'm trying to make some connections. So it's there for you, the reflection canvas. So what are you hearing about equity? What are you hearing about collaboration? What are you hearing about improvement? And then what do you want to take away from the session? So I hope you find that a helpful tool for this session and other things that you do in the future. Okay, I'm going to stop talking now, and I'm going to hand over to Seema to get us started. Thank you, Seema.
Thanks so much, Stacey, and good afternoon, everybody. My name is Dr. Seema Srivastava. As Stacey said, I'm Deputy Medical Director at UHBW. I'll abbreviate it, it's a bit of a mouthful. And I also clinically practice as a geriatrician in North Bristol Trust, so 2 acute trusts in Bristol. I'm really delighted to be sharing some of the work we are doing on health inequalities in Bristol, North Somerset and South Gloucestershire, and the part we play as an acute provider collaborative. And I'm going to be linking this with the journey we're on as both acute trusts in delivering our joint clinical strategy, which was published in March of this year, with equitable care really being at the heart of this. And so I hope to sort of link that strategy and decision making to the work that we're doing in terms of health inequalities in the next few slides. And so, Chloe, it'd be great if we could move on. So who are we? As I said, we're Bristol, North Somerset and South Gloucestershire. That's our ICS patch. It's 1 million people in our population that we serve. It's not dissimilar to probably your patches across England. We have 3 local authorities, 6 integrated locality partnerships. We have the 2 acute trusts, 1 community provider, 1 mental health provider, 80 GP practices, and all sorts of other partnerships across that patch. We, in our area, have the city of Bristol, so that urban city area, as well as rurality in South Gloucestershire, and this coastal area, which we call Weston Supermare, and some of the related areas. So there's quite a mix of this geography here. If we move to the next slide. And this describes our demographics in that population. And so you'll see there are differences in terms of average age. There's levels of deprivation, particularly in the city of Bristol, but not exclusively, and the concentration of our ethnic minority groups and global majority in Bristol itself. And like many places, sadly, across the land, we see the link between areas of deprivation and life expectancy. And so in Bristol, there's almost a decade difference in terms of that life expectancy between the people living in the poorest areas of Bristol compared to the wealthiest. And we see this also in North Somerset. And I think this has really mobilised us, as many other places in England and in our health and care systems, around reducing health inequalities collaboratively, and certainly something that is really key in the work we're doing as provider collaboratives. If we go on to the next slide. And certainly when I've been listening back to some of the recordings for these sessions, it's really clear to me that provider collaboratives look different across the country, not one size fits all. And in our context in BNSSG, we have 3 main provider collaboratives in our primary care and our mental health health care providers, as well as the 2 trusts, MBT and UHBW. And when this started, where we started was with that board-to-board development and regular executive team meetings between the acute trusts. And it was through those conversations that support for a joint clinical strategy started, through both chief medical officers, in terms of how we would deliver on the aims of provider collaboratives, through that clinical strategy. If we go on to the next slide. And you'll be familiar with those key aims of provider collaboratives, but they are well rehearsed, but worth noting. They've really been a strong thread in our conversations, the work we've done around reducing that unwarranted variation and unequal access in experience and outcomes as well. Acknowledging the fragility, particularly between our acute provider organisations and that opportunity to provide mutual aid, wanting to look at how we configure our services for better outcomes and productivity when we know resources scarce, and also wanting to be true to that commitment as anchor institutions and organisations and that broader social and economic development. So that's really that sort of national why of why we work as provider collaboratives. If we move on to the next slide, we've thought about what this means locally in BNSSG and how we started engaging our senior leaders between the two trusts in particularly focusing on equity and thinking about how we design and deliver a joint clinical strategy. This is the Gloucester Road in Bristol. I know there are probably many Gloucester roads across the land. And but in Bristol, if you stand in the middle of the road and you turn right, you go to one main site of one acute trust, and you turn left, you go to the other one. And we asked ourselves as clinical leaders and as operational and corporate leaders, if my loved one becomes unwell in the middle of Gloucester Road, would we experience different care if we turned right or if we turned left, if the ambulance took us right or left? And if there was a difference in outcomes, experience, access, were we okay with that? And we're not okay with that. And we can see differences when we look at whether it's our model hospital performance data, whether it's our friends and family test, our GIRFT and national audits. There are many lenses through which we can look at this. But the experience of care is different, and this really engaged our teams in wanting to think about how we could collaborate and work differently to deliver those aims. We move to the next slide, please. And so over a period of 18 months, we have worked between both organisations to engage a number of stakeholders within the acute trusts to think about how we can reach these key aims that we've agreed on to provide that seamless, high quality, equitable and sustainable care. Seamless in that there are no gaps experienced by people moving from one place to the other for their care. High quality and really mobilising and building on the great research and quality improvement that happens in both trusts. Equity is a golden thread through all we do, but really wanting to eliminate that unequal access, particularly. And sustainability, we know that our teams are under so much pressure. We wanted to make sure that this is care that can be delivered and sustainable experience between those teams. So that's where we are currently with our joint clinical strategy. It was published in March, and we are now in the implementation phase. It's all great when you're sort of getting these strategies together, but actually being able to make it real is not without challenge. We move on to the next slide, Chloe, that'd be great. What was really clear about what our teams shared with us as we went through this engagement and strategy development was they wanted to know, if we say that we want something to change across both trusts, how will we know it will happen? And I think governance has been a really important thing that our teams wanted to see that thread through to the Acute Provider Collaborative Board. So this slide shares a little bit about how we've arranged ourselves. We have a joint clinical strategy steering group made up of executive leaders from both trusts, as well as clinical service leads and corporate leads. That feeds into a joint executive group that then feeds into the APC board. Through that structure, it's also become really clear, and our teams have been able to share with us that collaboration can only go so far, but if the corporate enablers and enabling services are not part of this, we'll get stuck. And so making the money work between two organizations, the HR processes, the digital infrastructure has been a really important part that we've paid attention to in this next phase. If we move on to the next slide. And in terms of implementation, both trusts use one improvement approach. We call it patient first, and within that, each trust has agreed improvement priorities within strategic themes. You see two triangles there. So we have, whilst the same improvement approach, there is different language that is used, but broadly the same in terms of those strategic themes. So, for example, in one trust, in terms of health inequalities, there's language around timely access for all. In the other trust, there's the strategic theme of in and for our community, really speaking to that anchor commitment and designing in equity from the start. And so these sort of high-level aims are fixed within both trusts, but they are expressed differently, and that is a challenge. So if we move on to the next slide. And in terms of those high-level aims, how that feeds into health inequalities work in the trust that I lead in, UHBW, we have health equity delivery objectives. They have been drawn from some work we did back in 2022 when we invited an external baseline review of equality, diversity, and inclusion in the trust from a public health consultancy with expertise in equity. And we came through that review, explored these objectives and agreed them through our own internal governance, really wanting to work with our wider partnership, improve outcomes for patients in terms of unequal access, and building confidence and skills for our people in delivering improvements in health equity and being data-driven. We move on to the next slide. In the other trust, in North Bristol Trust, the development of their health equity steering group has been much more organic. It's now becoming more formalised in terms of its governance. You'll see here, many of you will be familiar with project charters, and this fits very much with our patient-first methodology. And they describe their goals and governance in this way, but actually broadly the same goals in terms of access to care, focusing on education and capability, and being data-driven. So again, just describing the challenges of organisations that are working collaboratively and moving on that journey. But if we move on to the next slide, we're at a point in time where the degree of collaboration is shifting. Governance and priorities are broadly the same, but described slightly differently. And there's a choice. You could choose to wait until all your ducks are in a line, in a row, and then start working together because everything looks broadly similar. Or you can really translate the best of what both organisations are doing and align as much as possible, weaving in that best practice and get on with improving some stuff. And so we very much wanted to go forwards and know that the rest will come. And so that's what I'll describe in the next few slides. So if you move on for me, Chloe, that'd be great. So where we were in the start of 2022 on our journey of collaboration was looking at a really powerful statement in priority in our planning guidance around restoring NHS services inclusively. And I noticed in our previous sessions, this has been something that many speakers have focused on. This really did bring us together with that core 20+5 framework for adults and children and young people to create one of our first acute provider collaborative system groups, where both myself and my counterpart at North Bristol Trust, Deputy Medical Directors, co-chair, a system elective recovery health inequalities working group focusing on that priority one. And we have a number of stakeholders who have joined us since that time, working on how we can improve restoring our NHS services inclusively, particularly in that elective care space. And if you move on to the next slide, I can share where we started. We started by looking at our data, both trusts, and looking at where we were seeing the most difference in terms of elective care and missed appointments, which I know many trusts are working on, has been something that has really been an area where we thought we could make the most impact in our services. And so when we looked at our data, particularly in cardiovascular health, we could see that DNAs or missed appointments had a huge sort of link in terms of people living in the most deprived areas in BNSSG. And ethnicity was definitely linked in our data there. We, as Stacey said, I'm a member of Q, as many of our other colleagues in our elective recovery health inequalities group. And so we applied for some Q Exchange funding last year. We won, which was amazing. And some of my colleagues who've led the work are sort of represented on this slide. And we have been working using quality improvement methods to address this issue. And as you see here, the main theme is around co-design with our communities and working together as acute trusts, sharing our data, sharing our learning, and sharing resource as well to enable that key aim of reducing that inequity. If you move on to the next slide. Thank you so much. And again, using that patient first quality improvement, continuous improvement methodology, we have been using project charters to describe the work that we're doing, the governance structures, the key roadmap and criteria that get us to the next stage. And in that, our governance is described as it is now. There are two sets of groups that we will report up to, as well as our system group within each trust. We, though, have a commitment to continue to collaborate and share as a single group. We move on to the next slide. Our methods and the work that we're doing in that collaborative group are very true to our continuous improvement tools that you'll be familiar with. We've been working with our stakeholders in both acute trusts. This is specifically working in cardiology, and also going out to community groups. We're really lucky that we've got great relationships in BNSSG with a number of VCSEs and community interest companies. And they really are, those community partnerships really have enabled us to unlock some really powerful insights from our community, and using those insights and engaging our service teams in thinking about what could solutions be, what's the problem we're trying to solve, and what could those solutions be in terms of reducing missed appointments in these groups. If we move to the next slide. And the top themes probably won't be surprising to you. Communication, it was what we heard was one of the biggest barriers for our patients trying to access services in our cardiology outpatients. People not receiving letters or not understanding the language that they're written in, not sort of understanding what the appointment's for. As you can imagine, people have been waiting a long time, and difficulty once they get to the hospitals and navigating where to go, as well as the flexibility of our appointments, particularly for people who are on lower incomes, struggling to take time off work. and being able to access interpreting is a really big thing. Transport is a huge headache, particularly in the centre of town. We've got clean air zone as well, and that has its own challenges, even though we're working with our local authorities to enable people to still access and come to the hospitals. If we move on to the next slide. And so in terms of interventions and the improvements that we're now testing together as acute trusts, we're using some of our patient engagement digital platform opportunities. So we're using something called Doctor in BNSSG that does, for people who are able to access digital tools, help with some of the issues that our patients have told us about, acknowledgement that we do have their referral, knowing how to keep well, being able to look at scheduling and rescheduling your own appointment, and then also we're able to check that people still want to come. And so there's that in itself has been a huge has made a huge impact that you'll see on some of our data. And there are patients who aren't able to access those digital tools. And so one of the things we heard from our community is that wouldn't it be great if we had someone who was focused on those patients where they just need something different. And so with some of the funding that we've got, we've been really blessed with getting Eloise, who's our outpatient quality access coordinator, who's working across both trusts to really phone patients up who are in those IMD groups, low IMD groups, and find out whether they have any questions or needs in terms of getting to their appointments, or could we deliver their care a different way. If we move on to the next slide. And so this is some of our data. You'll see that here we're showing all of our waiters, people who are waiting for cardiology appointments from our lowest IMD group, as well as some of our ethnicity data, acknowledging our ethnicity data is not as complete as we'd like it, comparing that to people from the least deprived groups. And you see that missed appointments are coming down across the board. And I think that's really important in terms of this work, is that if you make things better for one group, you generally make it better for all. We're still not where we need to be, but there's some early indications that we can start making a difference here for some of the people who are most marginalised and vulnerable and have the poorest outcomes. Next slide. Thank you very much. And so what this journey has brought us to now is, with the joint clinical strategy being live, working together as two trusts more and more for all our clinical services, with some pace behind it now, as well as some confidence that we have now in working on health inequalities together as acute trusts, is that we've been able this year to submit a shared acute provider health inequalities priorities plan to our ICS and our ICB. You'll see in here that some of those projects and that priority areas are individual. So North Bristol Trust might are focusing, because they provide our urology services, for the patch on prostate cancer in Black men, whereas we have in UHBW, we provide children's services, have a specific project on oral health in children, but then there are a number of joint projects around people experiencing homelessness, our Gypsy Romana traveller communities, and people with learning disabilities. And so it's really great that we're able to come to our ICS with a joint plan, of which now we can mobilise the improvements. And you'll see that data is a really important priority for us, being able to understand our population health and the data that's driving us to where we need to focus and put our improvement effort is so important. At the moment, it does still sit in pockets. We go to the next slide, please. So what we're trying to do in terms of data is align our dashboard. So this is on the left, UHBW's health inequalities dashboard, and on the right, MBT's. They are broadly the same, but it's sit in each other's in their separate data warehouses. We've made sure that we align them so that when we're in a position that we can share the data across the acute trust, that it will be simple, and also that our teams are looking at the same sort of data. They're not looking at a run chart on one and something else on another. We could do better, but this is where we're getting to with our BI teams. And if we move on to the next slide, please. And the ICS with the influence of the System of Elective Recovery Health Inequalities Working Group, do need to change the name, it's such a mouthful. We've been able to influence a planned care inequalities dashboard. So this doesn't just look at the acute trust, it also looks at our independent sector and other providers as well. And so that is getting us closer to looking at our data together and looking at where we go next in terms of our improvements. Move on to the next slide. I think I've got a couple left. So just leaving us here with some challenges. So whilst as an acute provider collaborative with our joint clinical strategy, where we're able to start working together with much more structure and much more, I guess, pace in terms of where we need to get to not only reduce health inequalities, but also improve our services across the board. We are in a very changing landscape with our ICB maturing. We have what's called health and care improvement groups now, which are really driving the ICS improvements and link into our joint forward plan and the ICS strategy. And so we're, as an acute provider, learning how to fit into that changing landscape, and that isn't always easy. And if we move to the final slide, and it's just leaving you with this challenge. I've talked about how strategy and decisions around priorities can lead us to work together and focus on improvements to improve equity. It does remain, though, a challenge at this point in time when we have a number of different strategies. I mean, those are just two, the ICS strategy and our joint strategy. There's a whole world of strategies being published at the moment, and trying to make sense of that for the people who are working with us in our teams is something that we're just, that is our focus at the moment. We've really got to make sense of this for our people. And I'll leave it there.
Wonderful, Seema. Thank you so much. So much richness in there and insights, particularly, noticing when you're talking about challenges around alignment and language and what choices you make and what's good enough actually in terms of starting to get the work done. It was really interesting. Thank you. I'm hoping we've got some questions, but I might get us started with one if that's okay. So just interested around the development of the joint clinical strategy. And what were some of the challenges you had with the alignment across the senior leadership? Or in fact, were there any new opportunities that you discovered that were quite unexpected?
Thank you. Yeah, so this work is, when you think about provider collaboratives and the history we've had, particularly as acute providers, we've worked in an environment of competition between the two trusts historically, and then moving from that to collaboration, in some contexts it can be really challenging. And so I think it's really important, and we took our senior leaders through this journey with us to acknowledge that history, to really acknowledge that the past has not always been easy or felt collaborative, because I think ignore it at your peril, I would say, because people will just keep bringing it up otherwise. And so there's something around acknowledging the past and having that sort of ending, being able to end well for what's happened in the past. And then we've really taken time to appreciate how uncertain it feels, and senior leaders trying to make decisions when there is uncertainty and there will be disagreements, and as well as new thinking coming up that we're maybe not used to hearing, and being able to hold that as we facilitate some of this engagement work has been really important. And then I think for us, senior leaders have really stepped up to that commitment to wanting to see something different and see something new. And for me, a turning point was where we're in a room in a place where we commonly go to do get that headspace as senior leaders, and our clinical chairs and clinical directors saying, can we just get on and start doing this stuff now? And they'd said what they need to say, they just wanted to move on. And so yeah, there's certainly bumps in the road, but I think what's been really important is that sort of ending well, transition and new beginnings, and really being able to focus on that vision, and that equitable care has really been a driver for and helps us cut through some of the difficulty.
Great, thank you. And some of that, I think, is what you're talking about, is how you create the enabling conditions for change, actually. What are the key factors that you have to have in place? That's really helpful. I'm hoping we've got time to bring Stephanie in, and I'm conscious of the time that we've got in order to bring Andy in as well. So we'll keep it relatively brief if that's okay. But Stephanie, do come in and ask your question. Thank you.
Thank you, and thank you, Seema. Fascinating presentation. I can relate to a lot of it. Keeping this brief, we're also looking at joint clinical strategy. We've got 2 clinical strategies in place, both fairly new, and one of them is tied into the new hospital programme that we're working towards, so it's a longer term strategy. So both providers at the minute are quite reluctant, obviously, to go through this exercise again. One of the questions I had for you was, did you work closely with your ICB when developing the joint clinical strategy, or was it very much just the providers, and is that something you explored?
Yeah, thank you, Stephanie. And again, trying to keep it brief. Initially, we had that. I think it links into what Stacey was referring to in terms of bringing teams together. Having had that environment of competition, we did keep it very close in terms of the acute providers to enable that trust to build, and then sort of absolutely later on brought in our other stakeholders. So it really depends on your context and which way you do it. There's some reflections that feel that actually should we have done that sooner, bringing in patient sort of voice sooner as well. For us, it felt a good place to start was bringing our leaders from both trusts together.
Great, thank you, Stephanie, and thank you, Seema. Thanks again, Seema. We're going to hand over to Andy now, and Seema, we'll bring you back in towards the end for a slightly broader Q&A as well. Andy, over to you. Thank you.
Thanks very much, Stacey, and thanks Seema for a fascinating presentation, and probably unsurprised to learn there's quite a lot of overlap in what we're going to be talking about. So good afternoon, everyone. My name's Andy Heeps. I'm the Deputy Chief Exec and the Chief Operating Officer at University Hospitals Sussex, which is a very large NHS trust on the south coast. We cover 5 acute hospitals, 20,000 staff, serving population about 1.8 million. I'm a consultant obstetrician and gynecologist by background. Seema and I have got a few things in common. So not only are we both doctors, we both completed the Health Foundation's Generation Q programme, although at different times. And pertinent to what I'm going to talk about today, I'm going to talk about my previous role when I was Deputy and Interim Chief Executive at North Middlesex Hospital in London, where I worked for Maria Kane, who is the Chief Executive at the moment of North Bristol Trust. And I can see a lot of her presence in your combined strategy, Seema. So Maria's vision around dealing with health inequalities is one of the things that's inspired me into further executive leadership. So it's so nice to see that coming through. It's also nice to see familiar names on the list as well, and there's a couple of other Gen Q cohort members there as well. So hello, Claire, you know who you are. Right. So thank you, Chloe. Let's move through. So if we go to the next slide. I was talking to some colleagues the other day about the challenge I've got in my current trust, which is around our elective backlog. And we know that sort of came out of the COVID pandemic. And I think there's some real interesting narrative developing around COVID. It is amazing how quickly people forget. And I just wanted to reflect back on what we learned during COVID, because that's the thing that changed the way I think about collaboration and improvement. That pandemic disproportionately affected the most vulnerable population. So we risked forgetting the first 9 months of the pandemic. At the peak of the first wave, where I was, Black Londoners had approximately 2.5 to 3 times the risk of dying from COVID within 28 days of diagnosis compared to me. And people of an Asian ethnicity faced up to twice the risk. And during the second wave, Asian Londoners experienced a higher risk, so 1.7 times more likely to die from COVID compared to me. And for Black Londoners, that was at 1.5 times higher. That was a reduction from the first wave, but still a really staggering number. And Asian Londoners were particularly hard hit in the second wave, partly due to the virus's spread pattern, which initially affected the boroughs in the northeast of the capital, which was the home to many of London's Asian communities. And before the wide rollout of the vaccine in early 21, we observed an increase in COVID-19 cases amongst our Black communities, rising from about 10% of cases in early December to nearly 15% by mid-January. Asian Londoners accounted for about a quarter of the cases in January, despite comprising just under 20% of the population. So a disproportionate impact on populations within London of that horrendous disease. And it was that set me thinking about what are the criteria behind health inequalities. We understand and you know, the inverse care law we've known about for years, since Julian Tudor Hart said that our poorest members of society are those at highest risk of disease. And I'm a really visual thinker. So Seema was talking about the importance of data. That's going to come shining through in what I talked about, because this for me is about getting real clarity of data, because it really helps us to crystallize the challenges we have. So if we go on to the next slide, please, Chloe. This is a map of North Central London. You can see the red hospital is North Middlesex, which is where I was working as COO and Deputy Chief Exec. And the green hospitals, the Royal Free at the bottom, Barnet and Chase Farm, part of the Royal Free group. And going to the answer to Seema's last question, frankly, they were our competition. We had league tables about ED performance and RTT performance and cancer performance, and we would judge ourselves against each other. And when we were looking at the impact of COVID, I was really interested in where the hospitals sat in terms of the local index of multiple deprivation. So this is easily accessible to anyone. If you go to the CDRC website, you can put in a postcode and it will throw this up by ward on where deprivation sits in the UK. And you can see from the key at the left, the greener parts of the map are in the least deprived parts of the Community of London, and those in red, the most deprived parts of London. And North Middlesex sits on that A10 corridor, that big long block of deprivation. And so that really started me thinking about why were we seeing the impact of COVID represented in that poorest community? What was that all about, and how could that inform then improvement work that we needed to exploit our NHS partners in order to provide for that poorer population? Because the NHS is a single blue lozenge at the top of our letterheads. People think about the NHS as a single organisation. They don't care about our competition as different providers. They don't care about the fact that as clinicians, and particularly as doctors, we're really guilty of saying what I do in my place is better than what you do in your place. They just see it as the NHS. They pay their taxes to support it, and they expect to see equity of access across that. So I wanted to go into the data a little bit more. So if we move on, please, Chloe. In the 2019 English IMD, it showed that Enfield had risen from the 12th to the 9th most deprived London borough. And that is a real surprise, because there's a significant part of Enfield that is incredibly rich. But because that inequality across the east and west balances, the borough average often hides the true extent of deprivation across a wider range of measures. So we took part in something called the Enfield Poverty and Inequality Commission. If we move on, please, Chloe. And this is just some of the data. So Enfield, 11th highest rate of child poverty in the country. 1 in 5 workers are low paid and on 0 hours contract. Almost half of pupils in reception class had English as an additional language. It was the highest part of London for evictions from private rental properties, had the 2nd highest level of serious youth violence in London. And women in Edmonton Green, that you can see in the red bottom corner, which is exactly where the North Middlesex was located, could expect to live 28 years of their life in ill health. 1 in 5 of all households in that ward lived in overcrowded homes. We could start to see why COVID was a massive challenge. An infectious disease travelling amongst the community dealing with these challenges becomes a real issue for us to deal. If we go to the next slide, please, Chloe. About 4% of Enfield residents weren't registered with a GP. And the ED at North Middlesex, which was designed to see 300 attendances a day, was getting 600 visits a day just before COVID. In terms of public health grant per head, in Enfield, there was £48 spent per member of the population, compared to Islington in central London, which spent more than double that on public health in the area. 20,000 people with unmet mental health needs in Enfield, and the life expectancy gap between women in the richest ward and the poorest ward was 8.5 years. And the story was similar in Haringey. If we move on, please, Chloe. You can see here, so that line down the middle where the difference in colour happens, that's the line out of King's Cross. And on the left, you've got Muswell Hill and Alexandra Palace, Highgate, the richer part of Haringey, and on the right, and White Hart Lane at the top is just below where North Mid is based. You can see that you're back into the most deprived deciles for deprivation. And again, looking at some of the data that comes out of Haringey, if we move on, please, Chloe, you can see that the main cause of early death in Haringey, lung cancer, heart disease, significant contributors, and the top 5 risk factors for long-term conditions, poor health in Haringey, poor diet, smoking, high blood pressure, physical inactivity. And it is really stark that it is that simple. So this isn't about doing anything particularly special. If we want to get into this, we just need to get into the basics. I don't tend to talk about the excess alcohol bit because I think I'm probably a contributor to it at the moment, but actually a significant challenge in some communities and a lot of stigma around alcohol drinking, which I'll touch on shortly. So if we move on, please, Chloe. So what we decided to look at, there's that sort of apocryphal tale in East London that if you go along a tube line, you will see people have a lower life expectancy as you move from west to east. So we decided to look at 2 bus routes across Enfield and Haringey. So Rich Cockfosters in the north and Rich Highgate in the south. And as you moved along those bus routes towards North Middlesex, healthy life expectancy, so the number of years you can expect to live well for men and women, dropped significantly. So almost, in fact, over 10 years in Enfield, and even higher number in Haringey. So if you happened to have been born in those parts of London and were still living there, just because you were further down a bus route, your chance of a healthy life expectancy were reduced. So that gave us a real burning platform coming out of COVID. We understood why we'd taken a disproportionate hit, and we could start to see the data in an extremely stark way that was telling us we needed to do something different. But we were a small, single-site NHS trust with significant challenges in waiting lists, in ED performance, in cancer performance, and it was just really clear that we could not do that by ourselves. But we had a really, really tribal set of consultants and a previous attempt to merge into the Royal Free Group on the basis that coming together into a single organisation would benefit the organisation had gone poorly. So as leadership teams, the North Mid and the Royal Free executive teams came together, and we felt we should come into a collaboration. This was in line then with the national direction that we needed to collaborate in order to improve health inequalities. And so we developed a partnership agreement, and we developed it around 6 key pillars. If we move on, please, Chloe. So those pillars were that local people should have speedier access to specialist care. And what that meant was, if you lived around North Mid, you should have a better chance of getting the specialist services you might have needed at the Royal Free, and you shouldn't be disadvantaged just because you lived around a DGH in a poorer part of London. We would together develop a North London surgical hub that I'll talk about at Chase Farm Hospital, a new approach to quality management, and we introduced patient first as well at North Mid, and actually patient first, one of the earlier trusts to develop that is the trust that I'm now in, and that approach to quality improvement of being data driven and incremental change, I think, is really key in driving innovation. We wanted to get a combined approach to provider reliance, so it didn't feel like one organisation was winning and one was losing. There was a real challenge in community services that weren't particularly focused around the North Mid site. So actually, how could we move more care out into the community? And as North Mid, we couldn't make that case within our ICB, but together with the Royal Free, we had a much louder voice to amplify how community services should be wrapped around the trust. And then both of us were struggling with primary care, and there became the opportunity to have a bit of a quid pro quo with the ICB and the regional teams on, we will come into a partnership agreement, but we need you to invest in primary care to make it work. I just wanted to come to the North London Surgical Hub. So a large part of the data, if we move on, please, Chloe, was saying that we had significant numbers of population who worked on 0 hours contracts. They found it incredibly difficult to access healthcare that didn't mean they were then losing money, and that we particularly had a disproportionately young population that required orthopedic intervention that was preventing them get back to work. We had a significant issue at North Mid of on-the-day cancellations because we were trying to run elective and non-elective orthopedics through the same site. Quote from one of our staff nurses, having to cancel a patient on the day of their surgery, probably one of the worst bits of my job. Makes me feel like I've let the patient down and haven't done my job properly. And that quote from one of our patients who'd been in pain for over a year, having to wait even a few more hours is too long, let alone being cancelled. So the Royal Free had opened a new Chase Farm Hospital. It had barn theatres that were underutilised. And so coming together in partnership to develop a surgical hub where our staff, our orthopaedic surgeons, could go and operate free of the challenges of non-elective work, and really start learning from the work that happened at the South West London Elective Orthopaedic Centre was really, really important. It had its challenges. We might come on to it in some of the questions in terms of people's identity and competition, and people feeling that they wanted to maintain their identity locally, but actually showing people the benefit of lists that start on time, are really, really productive. You know, surgeons like cutting. So actually, if you can make that easy for people, you will maximize productivity and you can start to really address waiting. We talked to our local population and actually engaging, and Seema touched on co-design with patients, but we found that actually talking to population groups, so particularly in Enfield, representatives of the Turkish community, incredibly important to ensure that we weren't designing services that felt right to me as a middle-aged white man, but actually felt relevant for people who were needing to use services. So how were we putting on clinics at a time of day? As I say, I'm a gynecologist by background. Actually, women wanted later in the day appointments because they needed partners to be at home to look after children. So appointments at 10 o'clock in the morning that fit my job plan might not meet those members of our population who really needed access to. So if we move on, Chloe, the work we did, and I would strongly encourage colleagues to work with their local health watch. They are incredibly, incredibly powerful and sensible and wise organisations. And actually, They brought the voice of partnership agreements should bring additional money and resources, demonstrate benefits on how services could be improved, demonstrate understanding of the local population's needs, and a really important thing where people want their local hospital to still feel accountable. And as we come together into these wider, bigger organisations, most people we know don't really care about big organisations like Wall Free Group or University Hospitals Sussex, or if UHBW and North Bristol come together into a huge organisation. They care about their local hospital, which is where they go to access services, and staff care about their local hospital where they work. So that becomes that's a really important piece, that we think about what that accountability still looks like. So I just wanted to finish, because I'm aware we're running over a little bit, on what I think the principles of collaboration should be. So if we move on, please, Chloe, I think it's my last slide. So it's really important that you have a shared vision and goals. So establishing a common vision and set of goals focused on reducing health inequalities. There's a big risk at the moment, because the national planning guidance says we should form collaborations, that people are collaborating because we have to collaborate, and we're not collaborating because we want to do something. So having a real sense of what you want to do is incredibly important, and ensuring that all partners are committed to those shared objectives and understand their roles in achieving them. It's important to engage a wide, diverse range of stakeholders, including those from the communities you're trying to serve. I have a big issue on the presumption around everyone having access to a smartphone with a data plan. I don't think that's true in poorer communities. One of the things we learned at North Mid was you couldn't rely on someone's mobile number, because people would be buying pay and go phones that they dispose of when the credit ran out, and a new one would be bought. And so that digital inclusivity is incredibly important. So being as equitable as possible. You've got to be transparent. You've got to foster an environment of openness and honesty, share data, insights and challenges openly. If you're struggling with something, tell your system partners that you are, because they will help you forward. Involve community members. Data-driven decision-making is so key. Use the data to identify health disparities. We didn't go to the biggest area that we should have gone to in this partnership, which was we should have all wrapped around getting people to stop smoking. It was the single biggest contributor to poor health in the area that we were in. And the risk is, and I think we fell into this, we wanted a fancy surgical hub that was going to crack through orthopedics, but actually stopping smoking and getting people to lose weight will be the biggest impact things we can do. And the data keeps telling us that. The issue is you don't get the quick result off it. It will take years for that to come through. Part of our challenge in the NHS is we want really quick outcomes. Actually, the bigger changes in outcomes that we need to see for patients and our population take years to come through. Sustainability, so focus on creating sustainable health improvements rather than short-term fixes. Develop long-term partnerships that will help you secure ongoing funding and resources. It's not ignoble to sort of negotiate in that, saying if you want us to collaborate, what do we get for it? How do you help us to make this successful? I think working across different sectors. So the whole point of integrated care systems is that we shouldn't be so introspective and just talk to each other. How do we talk to the voluntary sector? How do we talk to patient groups? How do we talk to local and further education? Again, Seema mentioned being an anchor institution. You know, we should be absolutely linking up with colleges of further education and saying, train people up that we can employ, and actually we can employ them and they'll have a decent salary and a decent quality of life, and their health will improve because they're living in better circumstances. Our responsibility to do that as part of the community we serve, I think, is so important. We need to strengthen the capabilities of all partners. You need to provide training. This doesn't just come because you want it to happen, and training people together when you're collaborating is a great way of making sure that those relationships stick. Adaptability and innovation. So be willing to adapt strategies based on emerging evidence. If what you're doing isn't working, stop it. Don't just do it because you said you were going to collaborate and do something. If it's not working, stop it, do something else. Our time, our energy, our resources precious. You know, the whole principle behind continuous improvement, PDSA, is if it's not working, it's fine. celebrate it because you've learned something, and move on and try something else. And then have really clear accountability mechanisms to ensure that you do what you will say in a partnership, because if you do what you say you're going to do in a partnership, your partners will feel that they have to come alongside and be accountable as well, and regularly review process and make adjustments as needed to improve the outcomes. And I have a simple test for organizations that are collaborating. If they can't answer, how is this making your life a little bit more complicated? They're not properly collaborating. If we're properly collaborating, we should be taking a bit of a hit. It's a bit like, I dare say, a marriage. You compromise a bit to make the whole a better thing to do. So it's a really good test to say, am I really having to do something different here? Because if you're not, I'd argue you're not putting everything you could into the collaboration. I will draw that to a close there, Stacey, and looking forward to a conversation. Thank you, Chloe.
Thanks, Andy. Very wise words there at the end as well. It is hard work, and it has to be, doesn't it? In terms of building relationships across organisations. Thank you so much. There's so much in there, and really appreciated your dive into the data as well. Some really stark realities there, wasn't there? I, of course, have some questions, but I would like to start with all of you rather than take up the airtime. So I'll just see if anyone has anything burning either in the chat box or whether you want to raise your hand. Otherwise, I will jump in to warm us up. We've got until 1:45, haven't we? So we've got about 10 minutes or so. I'll get us started, shall I? It was really helpful, Andy, to hear about the partnership agreement and those principles. And I was interested in the kind of leadership and behaviour element of that. So as a board member, how do you get that alignment across the board on your new strategy? And firstly, kind of the importance of equity, but also the expectations of board members in terms of how you show up and how you lead in that space.
Yeah.
And just in any kind of learnings or reflections around that.
So I think we were really lucky. I think the chair at the Royal Free at the time was incredibly good at getting us into a place of discomfort in terms of, this feels awkward, doesn't it? But that means we're in the right place to have the conversation. And I think he talked about, and what I learned from him was you bring a negotiation spirit to it. And I always used to think a negotiation was sort of something where you hid your cards and you sort of waited to play the trump card to sort of get what you wanted. What he taught me about negotiation there was the most powerful thing you can do is stick all the cards on the table. So actually, what are our issues at the moment? What are we struggling to fix? Because just hiding them doesn't make them go away. I describe it as not opening the tax envelope. You know it's there. It's not, you've got to open it, you've got to deal with it. So actually getting colleagues into a space to say, and I think board members are pretty good at this actually, and Ned's are usually incredibly good at saying, actually, we need to be the biggest critic of our organisation here to say, what are we not doing well? And we need to ask for some help. And I think what happens there is people say, well, actually, we've cracked that and this is how we did it. Or more likely, they'll say, you're right, we're struggling with this as well. How do we pool and get into it? And I think there's a bit of pre-work that you need to do, I think, because otherwise you can just get into a bit of a spiral of, particularly at the moment, everything's horrendous and where do you start? So a bit of pre-work where Ned's and exec directors sit together to say, and that's where the data comes in really, really helpful. And I think sort of, and again, making it really visual for people. So when you say to people in Enfield, we're in the 9th most deprived borough, and people sort of go, well, okay, I don't know, kind of know what that means. When you break it down and show that these wards along this road have this level of poverty, you really start saying, well, what can we do for that? That starts to be meaningful for me. So I think getting it into that space is the way you get into it. And then I'm a massive fan of just let it see where it goes.
That's really helpful. Thank you, Andy. Very insightful there. I'm going to go to Jennifer next. Jennifer, please feel free to unmute and jump in.
Hi, thanks, Andy. I was actually going to pick up on your comment around, particularly around smoking and those sort of wider determinants of the things which maybe aren't as whizzy and as glossy as a new surgical hub, but have a bigger impact. And then leaning to that, my reflection is that actually the NHS collaboration has managed to sustain post-COVID. And I think overall, with people are kind of enjoying moving away from the kind of false internal market stuff. But I'd see, and I see it interested in other people's reflections, the next challenge about how do we partner effectively with local authority, because some of the funding for the things which are going to make a really big difference, especially in equity, rely on that kind of partnership, and how we expand on kind of the anchor institution. And I'm interested to know people's experiences and how they managed to make that work, in that it's a good idea, but that final joint funding bit where people go, okay, this finance, all the finance directors have signed it off and now we're all paying in.
Yeah. It's really hard. I'm struggling with it at the moment. A real challenge in terms of we've got a very challenged local authority financial position, and I think that's the same across the country. So we're using the Better Care Fund, and we're trying to say, actually, how is this working for us? How is this working for any of us? And where's our accountability on it? It kind of goes to the point I made, which is people like me have to be big and brave enough to say, I'm willing to put some money into the pot first. So I think health has to say, we're going to stick something in. We can sit there all we like and say we're holding the risk from you by people not doing, you know, what they need to do, or all the rest of it. But actually, it's a bit of money where your mouth is. It's a bit like the principles of feedback in radical candor. You can't give someone feedback until you've asked for it back from them. And I think understanding from local authorities how you impact, how we impacting you, because we frustrate them hugely with some of the things that we do. And some of the ways we prepare and don't prepare patients to sort of come out of hospital in terms of the inpatient flow bit. So I think it goes to that vulnerability bit. I think you show up and you say, how can we help you, local authority? Because I think that's the thing that will start to build trust for them to ask back. The other bit on that is, I think you're right. I think it has sustained post-COVID. And I think this is the sort of thing where building relationships in peacetime. So don't make it your big crisis the first time you get around a table to talk about some of this stuff, because that puts people in a very defensive position. But actually, how do you build the relationships with people over time that mean you can get into these sticky things in a much more sort of iterative way? But I've not fixed it yet, so I'd love to hear what other people do.
Thanks, Andy. We've got one question from Claire. Anything from you, Seema, in that part of our discussion? Could see you nodding.
Yeah, I mean, yeah, no, we've not fixed it either, I'm afraid. There's something building on what Andy said around accepting that as an ICS, that funding will go to places where we as acute providers might think, well, it should come to us. We've got all these issues, and to enable funding to go to a place, for example, really to where the delivery of care is understood best, is a role we can play by saying that's the right decision. So yeah, it's still evolving though, I think, for us in BNSSG.
Thanks, Seema. We've got a few minutes left. Claire, I'm going to squeeze you in because you've had your hand up for a while. So do come in, and Andy, Seema, we'll be relatively brief so I can let people go on time this afternoon.
Yeah.
Thank you.
Thanks to Andy and Seema. I'm also a GenQ fellow, so there's lots and lots that resonated in terms of how they've approached this, but also lots that resonated in terms of our experience in North East London with provider collaboration, with equity, with really, really significant variation in both equity of access but health inequalities. So really good to sort of, I suppose, feel kind of kindred spirits in terms of what you're doing there, and I think as they both sort of talked about that kind of paying attention to developing relationships at all sorts of levels across the system has been really important to us. The one thing that I had, just a quick question to both of them, is given where you are now and what you've done, is there one thing you would do differently? And I'm particularly interested, given Andy's in a completely different organisation, as to like how he's taken perhaps a different approach based, or the same, based on his experience at North Mid.
I do a lot differently, but that's part of the joy, isn't it, of doing it and learning. I think I'd have been braver with saying we don't know what to do. I think I got too defensive over what I was trying to protect. I think really, you know, there's really good improvement principle, isn't there, of define your problem statement. So what is it we're trying to fix here? Because I think we said we were going after health inequalities, but I think what we actually meant was we're trying to protect North Mid as an organisation, and I think that that meant that we weren't really consistent, because what we said and what we did felt a bit different, so we weren't authentic. That's my view, by the way, you know, where we're recording, but that's me being sort of really honest. It's really interesting. So I came to an organisation that had merged two organisations that had previously merged. So we're a big organisation. I thought, well, that's great because we're merged. So a lot of the relationship stuff will be easier, and it's not. So basically, organisational form does not necessarily mean that people collaborate. And actually, Claire, you and I were at North Mid, weren't we? And people wouldn't collaborate across wards. So these things are like fractals. You can take them down to levels. So I think it's the bit about, don't wait for the massive crisis to get people around the table to talk. I think my learning is just start conversations and get people building those networks, because that will build the improvement muscle and the collaborating muscle when stuff starts to get tough.
Yeah, I think I'd resonated with me, Andy, in terms of UHBW merged with UHB merged with Weston in 2020. So what a time to start doing that work. And sort of we've learned that paying attention to the learning from that was something we could have brought in much sooner in terms of our collaboration with North Bristol Trust. I think my key reflection is about comms and engagement. So you know, massive organisation to combine 25,000 workforce, taking people along the journey with us and not waiting until it's all lovely with a pretty bow on top to then say ta-da. I think we could have, if we could have started just sharing the mess earlier, people would be, you know, people are on the journey, but I think there'd just be something more that we could have brought to this work. So there's just something about being braver around that.
Thanks, Seema. Thanks, Andy. There's something that's going through my mind about both of your presentations and how it's almost like it's you're setting the stage for change, aren't you? The different elements that you've both been bringing in, where there are certainly some commonalities, but also a few differences as well. Really helpful to hear. I have no doubt that people here will be going back to look at some of the content through your presentations. Thank you so much for your time. It takes a lot to prep and find the time to come into these spaces. So really grateful for that. I'm going to bring the session to a close. If anyone on the call wants to keep in touch with others on the call, please pop your email address in the chat box. It's always helpful to build connections and relationships through these types of events. And Seema talked about learning there, and as you expect, learning is really important to us, and you'll see an evaluation link pop there on the slides and in the chat box as well. We want to respond to some of the hot topics and challenges that members want to focus on. So evaluation is a big part of that in thinking about what we're going to do next. The next event, while I'm at it, is on the 10th of July, using quality improvement to enhance maternity and neonatal outcomes. Have a look at that. We'll share some details on that as well. And finally, again, a huge thank you both to Seema and Andy for their contributions, thoughtful approaches to sharing in a really open way. We appreciate you giving your time. Such a rich and varied discussion. Thank you, everybody. I will let you go. Lovely to meet some new faces, and have a good rest of afternoon.